Welcome, everybody. I'm very glad to have you here. I am Dr. Dietrich, and I am pediatrics and pediatric emergency medicine. So I did a residency in pediatrics, loved kids, but really love acute care of kids. So I did a fellowship in peds emergency medicine and practiced 34 years with pediatric emergency medicine. Today, we're going to hit some of my favorite topics. These are kind of high yield areas that are frequently visited on board exams. And I'm going to give you some tips as we go through, and we're going to talk about some of the ways to approach some of these things to make it easier for you. I like to do a little bit more interactive. So there's going to be some questions that are going to pop up, and I'm going to give you a second to answer them in your mind so you can kind of think through it, because I think that helps reinforce things is when you have to think about, okay, what would be the answer for me rather than listening to me kind of read the stuff. So let's go ahead and start with a question. What is the most common cause of the pediatric surgical abdomen? So think to yourself, what is the most common? When you are taking board exams, there's two areas that they like to focus on. The first area is the most common, and the reason is it's common. So they want to make sure that you have a thorough knowledge and an approach to common problems. The other area that is really important is things that can kill you. And as I did a peds emergency medicine fellowship, I got better at my board scores, mainly because in pediatric emergency medicine, we look at the patient and we don't just look at, okay, what could it be? We think what's the worst thing it could be, and then go from there. So the most common cause of a pediatric surgical abdomen is going to be appendicitis. So I want you all to have a very good knowledge and an approach to appendicitis, because this is the most common cause of a pediatric surgical abdomen. And if you think about it, it's something that's really spoken about frequently and encountered frequently. So that's going to be why it's so important. So in children, we kind of split for appendicitis into two age groups. We've got the kids that are under 4 years of age, and then we have the kids over 4 years of age. And if you think about development, it's really hard for kids under 4 to tell you where the ouchie is. They just have a harder time giving you that history. So the kids under 4 years of age usually have a delayed presentation and a much higher rate of rupture. And usually it's not because anybody missed anything, it's just the kid couldn't communicate where they were having belly pain. The kids older than 4 are a little bit better, and they can point with their finger, and you can see my little kid in the picture pointing with his finger to his belly button, and that he's got an ouchie. So the classic history of periumbilical pain migrating down to that right lower quadrant isn't typical for our kids under 4 years of age. The kids under 4 years of age are usually going to come in with a fever, holding their belly, refusing to eat. So when you have a child that has, you're concerned about appendicitis, you have to do a diagnostic evaluation. So usually you're going to suspect in appendicitis in a kid who says, my tummy hurts. If they give you a child between the ages of 4 and 11, usually they're going to give you the pain started in the middle, migrated down to the right lower quadrant. That's the classic story for appendicitis. The younger kids, it's going to be not eating, my belly hurts, and when you push on it, they've got right lower quadrant tenderness, or they've got rebound and guarding. So the first test we usually do is something called plain films, which I'm sure you're familiar with because, you know, it's a kind of a standard x-ray that we do. What you're looking for on the plain films is there any free air under the diaphragm? And you can look at these and see, no, there's not. We don't see any kind of black line underneath the diaphragm, so that looks good. Then we look and say, does it look like there's any obstruction? Well, there's some gas, and we don't have much gas in the pelvic area, and we have gas above it. So yeah, that does look a little concerning. And if you look right down in the right lower quadrant, and can you guys see my arrow? There's a little white stone right here, and this is called an appendicolith. And if you see an appendicolith in a kid that has abdominal pain, you've got to be concerned about appendicitis, and that's going to be related to it. And this was my attempt to blow it up, although it's hard to see, but right below the black gas, there's a little white stone that you can see, and that's the appendicolith. Now, what is the first study of choice that we would do in a child with abdominal pain that we were worried about appendicitis? Usually the first thing we do is going to be ultrasound. So if they ask you the best test to do in a child to look for appendicitis, it's going to be ultrasound. And the reason is there's no radiation. So ultrasound has no radiation. It's a bedside test. And in thin kids, it's actually pretty easy to do. What are you looking for? There's some guidelines. You won't need to know what they are, but there are some measurements that you take to see if you've got appendicitis. So ultrasound is going to be the first line choice. The problem with ultrasound is that it's not always right. And if the radiologist does the ultrasound and says, I couldn't see the appendix, might the appendix be in a different location? You can't rule out appendicitis with ultrasound. You can rule in appendicitis with ultrasound. So if they give you a question and you get down there and they say the ultrasound comes back and it's equivocal, they're not sure if there's appendicitis, and you've got a child with that right lower quadrant tenderness, you've got a positive Rothsing's, you're concerned about appendicitis, the test you need to do is going to be the CT scan. And the CT scan is the definitive test for appendicitis. So if they ask you for definitive, it's a CT scan. And I've got the arrow pointing to the inflamed appendix that you can see on this CT scan. And this is also the arrows pointing to the appendix with the stone at the end of it. So CT scan is considered the current standard of care for children for diagnosis of appendicitis. We start with an ultrasound. If the ultrasound is positive, you can call surgery and they will take care of it. If the ultrasound is equivocal and you're still concerned about appendicitis, you have to do the CT scan. And you can see that the sensitivity and specificity is very high, 95% and 99%. I can't believe I have to memorize all of this. The other thing that pediatricians are very known for is their cute baby pictures. So you will be seeing a lot of very cute baby pictures, pediatric pictures. So the other one that you need to know is intussusception. And you will notice that I'm sticking with the really pediatric disease processes. And the reason are, these are the ones they like on the exam. So you need to know, what do you think the peak age is for intussusception? And this is important, and I find that medical students make this error frequently, is that in pediatrics, we have the ideal age, not the ideal, the most common age group where diseases present. So somebody had said something about meconium ileus. What age group would you expect to be looking for meconium ileus? It's a newly born infant. So that's going to be in the babies in the first couple of days of life. That's when they're going to test you on it. We can also see it in CF patients older, but the most common thing what's going to be on your exam is a baby within the first 24 hours of delivery that's not pooping. And then you get a film and you're suspicious for meconium ileus. So it's important to know what age group and to think about that, because the questions they write for the board exam, and I've written board exam questions, we always stick to the typical scenario. We don't go atypical. That's clinical practice. But what we're trying to do is make sure you have the basic knowledge for these disease processes. So intussusception, when do we usually see it? It is actually the most common cause of intestinal obstruction in kids under 2 years of age. The usual age you're going to see it is in our little kids, 3 to 9 months of age. And what happens is you've got the intestine like this, and we think that in the kids under 2, they get like a viral infection, and one of their little lymph nodes in the intestine gets swollen and serves as a lead point. And what happens is they telescope. So their intestine telescopes on each other. So it slides like this. So what do you think your symptoms would be when it slides in? What kind of things do you think the kids would have? The kind of things that they're going to have are going to be, and this is the classic. So if they give you a 6-month-old male who presents with a 12 to 24-hour history of these crying episodes where the baby's just screaming, pulls up their legs, cries for 5 to 7 minutes, mom can't calm him down, then all of a sudden releases the legs and relaxes and acts fine, that's a classic story for slipping in, slipping out. Slipping in, screams, slipping out. And that's the classic story for intussusception. The other things that you can see are vomiting, because you can imagine if your gut's slipping on each other and you're blocking it up here, you may have some vomiting. Usually it's non-bilious. You can see bilious once it's completely stuck and nothing's moving. But on your board exams, usually what they give you is a kid with intermittent crying episodes, because they don't want to tell you it's belly pain. So it's intermittent screaming episodes of pulling up their legs, vomiting. Sometimes they'll have a bloody stool. And after they have these spells, can you imagine your intestines stuck? The kids are tired. So they're lethargic. So you can have these kids that are really tired. So that's the classic story you're going to get for a board exam. What do you find on physical exam? So usually, you know, in the STEM, they start with the history. So now you've got a 6-month-old with crampy, intermittent abdominal pain, screaming episodes, some vomiting. Mom may have noticed some blood in the diaper. A lot of times they just won't say anything. You do your physical exam. What do you find? The classic finding is a sausage-shaped right upper quadrant mass. Think slipped in. What's it going to feel like? A sausage from the outside. The abdomen may or may not be tender, but usually you're going to have, the story is going to have that sausage-shaped right upper quadrant mass. So what do? There are 2 approaches, and usually the approach is more clinical than it is for board exams. So clinically, what we usually do is I either have a high degree of suspicion, in which case they're going to air contrast or barium enema, or I have a medium degree of suspicion. If they have a medium degree of suspicion, I will usually start with an ultrasound because it's less invasive. And then if the ultrasound is positive, the child still has to go get the enema of whatever kind. If they give you a choice, they won't give you a choice because it's too controversial. You can do air contrast enema, saline enema, or barium enema, and you will find that is institution specific, so it will not be on your exam, but you need to know that enema is the diagnostic and the therapeutic procedure of choice. And this is the ultrasound, which has a target sign, which is the one loop scoped inside the other loop, and that's classic for intussusception. How successful are enemas? Really successful. The sooner you get them to enema, the better the kids tend to do. So the air contrast runs 70 to 90%, normal saline runs 95%. And so any of the enemas are a good choice. What will happen is the fluid will go in and then it's going to push against that stuck loop and then it pops. You can watch it as it pulls apart. And then as soon as it pops, they get air going up to the entire intestine. Usually once they've been reduced, the recurrence rate's very low. We watch them to make sure they can eat and drink, and then they can go home. Yes, on the ultrasound, it is a donut sign for you want to stick what, where, and this is going to be barium enema, and you can see where the arrow's pointing is the stuck point, and then you can see as the dye makes its way all the way through, and that's going to be successful. Some people will, you'll find that some of the names are going to be different. The donut sign is going to be for the ultrasound, looking at the ultrasound of an intussusception because you've got the 2 circles inside each other. The other thing you will hear people call it is the target sign. And so it's going to be fine either way. Usually what you're looking for on the board exam is they're going to say on ultrasound, you can see that there's a double circle on it, and that's going to be the point of the obstruction. Now, the Meckel's diverticulum is the other one they like to put on board exams. And what is it? You need to know that it's a remnant of the omphallomesenteric duct. So it's something that was left over. The rule of 2s is very helpful, although the reason we have to know about Meckel's, remember I told you, you have to know common things like appendicitis, and then you've got to know the things that can get you into trouble. And Meckel's diverticulum can get kids into trouble. It's only in 2% of the population. Most present by 2 years of age, and it's usually located within 2 feet of the terminal ileum. And so This is something that is infrequent, but because it can be a problem, we're very concerned about it. And I'm just looking back. For intussusception, the other classic finding that you will hear people talk about is the current jelly stool. Unfortunately, the current jelly stool to us, what happens to make that current jelly stool? I've got one loop inside the other loop, it's compressing it. That causes ischemic changes to the gut. And so the blood is actually dead, not dead gut, but dying gut. So current jelly stools, I've probably seen 200 to 300 kids with intussusception, and I've seen it twice, and it was not good. But that is the other one that if you get a current jelly stool in your scenario, that is going to be the other thing that is classic for intussusception. Now, what is the typical presentation for Meckel's? So this is really, really different than adults, but I want you to remember it. Painless rectal bleeding. So this is usually what they'll do is they'll give you a 1-year-old, a 10-month-old, a 18-month-old. The child's going to be under 2 years of age, and the child comes in with a diaper full of blood. I've only seen 2 or 3 Meckels, and honest to goodness, their diaper was full of blood, and it was bright red blood. I mean, it's like they pooped blood, but the kid's not crying. The kids actually looked fine. You need to check their vital signs because losing blood can make you tachycardic and trying to compensate for that blood loss, but most kids do okay. So if you get a kid that comes in that looks pretty good in that age group under 2, diaper full of blood, first thing you want to do clinically is we check it to make sure it's blood because I don't know if you guys have Jell-O, but strawberry Jell-O, when you poop it out, looks a lot like blood and it's guaiac negative. But real blood is going to be guaiac positive. So the first thing we do is we check the stool, make sure it's guaiac positive. If the Meckel's, the Meckel's is a little thing that sticks like this. And so when we talked about intussusception, sometimes we find Meckel's, I've only seen it once, but the Meckel's will serve as a lead point that makes that one piece of intestine scope into the other piece. So it can be a lead point for an intussusception, but that will not be on your exam. That's more important clinical. Someone is having trouble hearing. Am I sounding?
Right. Ma'am, you are fine. It's just that they might have any issue with the internet. We will get it sorted from the back end. No problem, ma'am.
Okay. Why does it cause bleeding? Well, if that's a good question. It is actually a remnant of the phallomesenteric duct. And so the cells that line it actually are like cells from the, when they break down or they ulcerate, they bleed. And so it bleeds from the inside. And that's actually one of the most common things you'll see with the Meckel's. Now, how do you make the diagnosis? It's actually, and this is the reason they like to ask it on board exams. So from a intussusception standpoint, what is your diagnostic and therapeutic treatment going to be? All of you are thinking enema, right? Meckel's diverticulum is a technetium scan. And that's why it is going to be important to know this because I think it's the only time we use this commonly in pediatrics. I put a little arrow to show you what happens with the technetium 99 scan is it lights up. And so it is a very easy way to locate a Meckel's diverticulum. And this is another one showing you 2 to 3 minutes. And then I put an arrow to show you 5 minutes, 10 minutes, and then you can see how it lights up. So what do we do for the Meckel's? Usually what will happen is when they're bleeding blood like that, we'll call over to radiology and we'll do the technetium scan. Once they do the technetium scan, those kids usually go to the, yes, they excise it. They go to the operating room and a surgeon takes it out. Now, the other big one from a ped standpoint is going to be malrotation with volvulus. And this is one of, if you can remember intussusception, you can remember Meckel's diverticulum, malrotation, and we're going to talk about Hirschsprung's disease. These are kind of the favorite pediatric diseases to test on because all of them have very serious consequences if we don't diagnose them. So what is malrotation with volvulus? Well, you know how the gut goes through that process of moving out and then moving in back while the baby's developing. If there's a failure of the normal migration of the bowel, an abnormal fixation, what can happen is it's not in the right way, and it can twist on itself. So what can happen is it can either block, or if it twists, it can completely cut itself off. What happens when anything twists? It loses blood flow. If you lose blood flow, the gut's gonna die. And so this is a surgical emergency. I have never taken a board exam where I didn't have a question on malrotation with volvulus. And I've taken like 8 recertification exams. They love this one, mainly because they don't want you to miss it. So this is a beautiful illustration that was done by medical student companions. Mr. Tisdale helped. Yes, I can read your text. So there's LADS bands, and what you can see in this next picture is because it's not fixated correctly, see how it twists around it? And then what's gonna happen when it twists is it's gonna cut off the blood supply and the gut's gonna die. I have seen 3 kids that have had malrotation with volvulus. The one was very scary. It was a baby that went home from the nursery, was doing fine, and then was 2 weeks old and started vomiting. And what's the classic type of emesis with that kind of twisting gut where it's completely obstructed? Bilious or non-bilious? Bilious, very, very good. So when you've got bilious emesis, the first thing on any board exam you should think, if you've got a baby under 30 days of age with bilious emesis, you should think to yourself, I'm worried that it's malrotation with the volvulus. The cause of malrotation is they're born with a congenital abnormality that you're looking at in this picture, and because their gut is not fixated correctly, it can twist inside. And so what will happen is it will twist. Not exactly long mesentery, it's going to be more free floating, and so it can float instead of being fixated. Classic history is going to be bilious emesis with distension. You know, that's a good question. I have no idea if the D-dimer beta-lactin amylase is raised. We don't classically use that for the newborns. But if it's under 30-day-old with green vomit, bilious emesis with a distended abdomen and a normal rectal examination, you've got to be malrotation with volvulus is your key concern, okay? What are you going to do? You got to make the diagnosis. Now, one of the things that when you're in a board exam question is, especially in pediatrics, if they give you a 2-week-old male that presents with bilious emesis, it's been going on for 12 hours, he has not been eating. Physical exam shows a heart rate of 195, blood pressure of 90/60, cap refill is 4 seconds, and his lower extremities are cool. And they ask you what the first thing you're going to do is. What's the first thing you're going to do? And their choices are fluid bolus, 20 mLs per kilo, blood products, antibiotics, or CT scan. Very, very good. IV fluids. So always go, when they say initial, start with the fluid resuscitation if the child is critical, and then go from there. Initial always means an intervention that's going to make a difference, usually hemodynamically or for the airway. Classical physical findings, they usually have a distended, tender abdomen. They can have blood in their stool because, again, you twist it and your gut's dying, you're going to poop a little blood. You can be tachycardic, poor perfusion, those signs of shock. And usually the emergency department, my job is fluid resuscitation, stat surgery consult, getting the kid ready for the operating room. What is the diagnostic study of choice? And this one is different also. So you can start with plain films to look and just see if you can see anything. Mostly when we get plain films, to be honest, we're looking to see if they're perforated, because if they're perforated, it's a surgical emergency and upstairs they go without passing go. If you get plain films on a kid with malrotation with volvulus, you're going to see a dilated stomach and proximal duodenum because it's twisting. The test of choice is going to be an upper GI, and you're looking for the ligament of Treitz, and this is what the upper GI will look like. So can you see how big the stomach is, how then you see the duodenal bulb, and then see how it corkscrews? That's the classic upper GI for a kid with malrotation, and volvulus. See, the volvulus is where it's twisted, and that looks like a corkscrew. And this was an even prettier picture of a huge stomach, duodenal bulb, and then a corkscrew. And that's the classic finding for a malrotation with volvulus. Focus of management, stat surgery consultation. Yes, honestly, they need to get to the operating room. Surgeons do their best to untwist things, save any gut they can save, excise dead gut, and hopefully they get there fast enough. And that's why this is a surgical emergency. The tighter it gets, the longer it goes on, the more gut you're going to lose. And so you can't afford to miss this. Most common, this is going to be under 30 days of age, at least on your board exams. In real life, they'll give you up to 6 to 9 months, but on at least the ones I've taken, it's usually under 30 days of age. Child comes in with bilious emesis, distended abdomen, tender abdomen. And so anytime you see bilious emesis, malrotation with volvulus is what you're worried about. He's waiting for someone to call him. Okay. This is the other one that they really, really, really like on board exams. It's called Hirschsprung's disease. Now, what is it? It is the absence of the Meissner and Auerbach autonomic plexus. So they've got agangliosis in the intestinal wall. Usually, it's limited to the end section, limited to the distal colon, but it can involve the whole colon. On your board exam, it usually is only limited to the distal portion. Boys are more commonly affected. Now, question for you, because you have to know what's normal to know when something's gone haywire. So, when do neonates pass their first meconium? When do the majority of them have passed their first meconium stool? Any of you who've been in the delivery room, yeah, usually it's pretty, yes, very good, within 24 to 48 hours of birth. The majority of them pass it within the first day, and I can personally attest to having been in the delivery room. A lot of them pass it right after they come out, or sometimes even before they come out, but that's a separate problem. So most of the kids we're gonna see, 98% of them pass it in the first 24 hours of life, and about 50 to 90%, and I will tell you on your board exam, it's 90%, don't pass their meconium in the first 48 hours of life. So when you're reading that question stem, usually it's going to be a baby under 30 days of age, 2-week-old, 3-week-old that presents with constipation since birth. When you ask mom, mom says they did not pass their first meconium in the first 48 hours. Very good point. It can be normal to go 3 days, but on your board exam, you will assume it's not normal. There's some literature talking about, you know, there's a percentage of kids that don't pass their first meconium till 72 hours, till 96 hours. But the point of the board exam and the point of this is going to be that we don't want to miss this, because again, this can cause serious problems for the neonate. So your assumption is going to be, if they don't pass it in the first 48 hours, you should be thinking Hirschsprung's disease. Or you can be thinking meconium plug is the other thing that you can be thinking. A duodenal membrane, where's the duodenal membrane going to obstruct? In the duodenal, right? So what do those kids usually present with? They don't make it out of the nursery, because usually what will happen is within the first few hours after birth, we try to feed them, and what do? They retch, they throw up, and if they throw up, it's usually going to be bilious because it's at the level of the duodenum. So if it's a newborn infant that is throwing up bilious emesis in the first 24 hours of life, you've got to assume there's a blockage somewhere that's not allowing it to pass. And if it's at the duodenal level, then that's going to be bilious, and that's what we're going to be concerned about. Which is the most common cause of constipation in children? Poor diet, and poor fiber intake, and loss of water. So this Hirschsprung's you're going to have to look through the stem, and you're looking for a kid under 30 days of age, did not pass their meconium in the first 48 hours, has constipation. And sometimes these parents are really treating it like they're doing rectal stimulation every day, 2 times a day, or they're giving them glycerin suppositories. That's not normal, especially in that newborn period. This shows you a baby on the left with a normal colon and normal nerves, and see how it dilates and it goes down. And then if you look at the right, you have that aganglionic segment where it forms a point of obstruction and everything dilates above it. And so the baby's got constipation. Now, what could happen? So no meconium in the first 48 hours, they present with constipation. So you've got a baby that's got aganglionic area down towards the distal colon, and you go to do a rectal exam, and you stick your finger in the rectum, and you feel this tight area, and then you pull it out, and the child has an explosive stool. That's the classic story for a small segment Hirschsprung's disease, because what happened is you put your finger in, dilated the part where the ganglion are missing, and allowed everything that was stuck above it to come out, and you'll get an explosive stool. Ways you can make the diagnosis: you can do a barium enema, and sometimes if you're not sure if it's a meconium ileus, a meconium plug, or it's Hirschsprung's, like you've got a newborn, they're 48 hours old, they haven't passed their first stool, you do the film and you see the soapsy sudsy stuff that's meconium, and you're like, oh, I'm not sure what it is. You can go ahead and do a barium enema. With Hirschsprung's disease, you'll see the transition zone where it's small to where it gets big. And a lot of people like the barium enema because it's therapeutic for meconium. So a lot of times you can clean out the plug and get the kid going. But if you see that transition zone, you're going to need to do a suction biopsy, and that's the definitive way to make the diagnosis of Hirschsprung's, is a suction biopsy. All right, ready for everybody's favorite, pyloric stenosis. So pyloric stenosis is a very interesting disease. So these kids usually present between 4 and 6 weeks of life. Usually they're white males, usually they're firstborn males. And usually, and they don't always, but they may have a history of dad had the same thing when he was a baby. So usually what you will find is going to be a classic story of, I'm hungry, I'm hungry, I'm hungry. So you think about the stomach, and then the pylorus has hypertrophy. So you've got this tight area right below the stomach. So what kind of vomit do you have? Bilious or non-bilious? Non-bilious, excellent. So you've got non-bilious emesis. So these are, I am a starving baby, feed me, feed me, feed me. And the mom will stuff the bottle in the mouth or go to breastfeed, and the baby will go gulp, 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 gulp. Uh-oh, puke. And it's usually projectile non-bilious emesis. And honestly, I had one mom who said, let me show you, and stuck the bottle in the mouth, and the kid ate 3 ounces and he hit the back wall. I was convinced at that point in time that she was right. I told her, I said, I would have believed you without that. But they really can get projectile emesis, especially what happens is the stomach dilates, it can't go through, and it just comes right back out. Typical lab findings, you know, they don't know why it is after 2 weeks, but we only see it in the older kids. Like, it's nothing that we see in the first 2 weeks of life. And usually what happens is, like, at 2 weeks of age, they start having vomiting, and it's always non-bilious. Usually the kids are starved, and the parents tell you, I feed them, they throw up, I feed them again, they throw up, I feed them again, they throw up. And it gets worse from 2 to 6 weeks of age. That's the usual time. Usually we diagnose them about 4 weeks of age, and that's going to be classically when they present. And how might you tell that a baby wasn't getting enough to eat? So say that I told you I've got a 3-week-old at home that I'm breastfeeding, and the baby has been eating, but he always spits up. I don't use the word projectile, he spits up. Electrolyte imbalance, that's a good thought. One of the things pediatricians do is we stick them on a scale. So if you weighed 6 pounds at birth and you come in at 3 weeks of age and you weigh 8 pounds, are you getting good nutrition? Yep. Absolutely. Babies usually gain 20 to 30 grams a day. And so when you've got that kind of weight gain, the kid's getting good nutrition. With pyloric stenosis, they don't gain weight because truly it can't get past their stomach. And so these kids usually will be, 6.5 pounds at birth, and they'll come in and they're 3 weeks old and they're 6.5 pounds. Well, that's not normal. You should be gaining 20 to 30 grams a day, and we should see that consistently. So that's a quick check that there's a problem. So if you're not gaining 20 to 30 grams a day, there is something wrong and I need to figure out what it is. Classic lab findings, yes, we got that right. Hypokalemic, hypochloremic, metabolic alkalosis. All you're throwing up is stomach acid. And so that's going to give you those classic lab findings. How do we make the diagnosis? My favorite test in the world, ultrasound. And here are some very nice pictures for you showing how hypertrophied the walls of the pylorus get. And then as they get more hypertrophied, they get narrow, 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 and then you can get a high degree of obstruction, which is why the kids vomit. This is an old one that shows how old I am. We used to do upper GIs before we had ultrasound so reliable. And what you can see is how big the stomach is and then see how narrow the pylorus is. And that's what the arrow is pointing to. So how do you manage pyloric stenosis? Good question. I don't remember what the diameter, what the measurements are that the radiologists use for how hypertrophied it is. You won't have to know that on the exam. Usually we don't do the barium because if we know it's non-bilious emesis, then we know the point of obstruction is going to be above the duodenum. And so we're going to be testing with ultrasound or a test that's in the upper part. If you've got an abnormal stool exam or rectal exam, that's when you're going to be using the enema. Or if you've got that right upper quadrant sausage mass and the intermittent pain, and then you suspect intussusception. And yes, you are correct. We do a pyloromyotomy. Rehydration. This is actually considered an elective surgical correction. So they usually do not jump up and down about this. If the kids' electrolytes are abnormal, we actually admit them and hydrate them overnight. If the kids' electrolytes are normal, some people will send them home and have them come back for an elective surgery. The surgery is completely correctable. Usually the kids eat within 5 or 6 hours and they usually go home within 24 hours. I have never seen transesophageal ultrasound of pyloric stenosis. Usually what they do is just abdominal ultrasound and then they can measure the pylorus. Yeah, and yes, you can use the upper GI to do with the dye as another way to make the test diagnosis. Most people prefer the ultrasound because, again, it's less radiation. And honestly, feeding a kid that's going to retch on you is never a good idea. So the ultrasound, we don't have to feed them anything either. Biliary atresia is the next one. This is another big one. And the reason you have to know this one is because this is a disease process that, if missed, has very, 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 very bad consequences for the neonate. So this is going to be absence or atresia of some part of the extrahepatic biliary system. What they usually present with is jaundice, hepatomegaly, and white stools or acholic stools. So what we're looking for is going to be, how when babies are born, their liver doesn't always have the correct kick-up of its enzymes. So what will happen is the babies will be born and we have physiologic jaundice. Does anybody remember how many days after birth physiologic jaundice usually happens? Yes, it's going to be usually within the first week. So usually you've got a baby that goes home, they start to get a little jaundice. We go ahead and check a level. We check a total bili. And what kind of bilirubin is usually elevated with physiologic jaundice? Unconjugated or indirect. So unconjugated, very good, or indirect is going to be elevated. Why do we do the total bili? Because if I do a total bili and my unconjugated is elevated, but I've got a gap between the two, Or some people will do a total bili with indirect and direct, because if your direct or conjugated bilirubin is ever elevated, that is never, never, ever normal. And there's actually been a push in the US to routinely screen babies for this, because if you miss this, it's such a big problem. So what is the management? They immediately get admitted. The reason they have to get admitted is because of this biliary atresia. The poor surgeons, bless them, only have a limited period of time, usually within the first 4 weeks, to get them to the operating room to prevent liver failure. And if you do not get them, if the Kasai doesn't work, these kids have to get a liver transplant. And so this is the big reason you'll find this on almost everybody's board exams in pediatrics, is because if this is not picked up in the first couple of weeks and they're referred to a surgeon, then the Kasai procedure isn't going to work because they've already got too much liver damage, and those kids are go in line for liver transplants. So that's why we're so careful with this disease. Now, TEF, there are a whole bunch of subsets, and you do not need to know them, mainly because it takes a lot of diagnostic testing, and that's not relevant to what you do. And it's really hard to test, to be quite honest with you. I've tried to write questions for things like this. It's very difficult. But what they usually like is a newborn that has, they'll usually give you, the child was born 12 hours ago. They've tried to feed twice. The child won't swallow, and the child is drooling, which is never normal in neonates. So the child keeps having mouth secretions pool and come out. Or they can give you a child that every time you feed, the child turns blue, has coughing spells, chokes, turns blue. And that's going to be a concern for a TEF. Usually what they will do, a quick check is going to be if you put an NG tube down a baby and then you shoot the film. If they give you a baby that's drooling, not taking their feeds well, and they give you a picture of the baby's chest, look to see how far down the NG tube goes. And if it's curled backwards, then that's absolutely an esophagus that is not complete. And so that gives you the diagnosis of TEF, and that child needs surgical intervention. Very good. Coiling of the tubes is exactly what you expect. Difference between projectile and non-projectile and cyclic vomiting. So usually projectile vomiting is going to be vomiting that is very forceful and goes out. If any of you have ever overfed a baby, baby stomachs are only so big. So if you give a baby with a 3 ounce stomach, 4 ounces, 1 ounce is going to come back out at you. And so but it usually like comes out and hits your shoulder. It doesn't shoot out. Projectile vomiting is never normal. But the little kind of emesis that comes out and just goes a short distance is going to be quite normal, especially if you overfeed the child. CNS can be related to projectile. Sometimes if you've got increased intracranial pressure, our kids will show up with vomiting. Usually it's non-bilious vomiting, and what time of the day is usually going to be the vomiting? Usually for CNS problems, it's going to be morning vomiting. So usually the kids, if they've got hydrocephalus, if they've got a brain tumor, those kids will usually have vomiting that's usually in the morning, and they will usually complain of a headache, and usually both of those things get better after they vomit. And that's kind of what they usually put in your stem. Cyclic vomiting is more of an older child diagnosis. It's not in the younger kids, and it's going to be what we think. They usually don't put that on your board exams because we're still learning a lot about it. But it's a cycle of vomiting that's usually going to be like a migraine, where the kids will get vomiting that starts like with not feeling well, and then they get cyclic, they'll get these cyclic episodes of vomiting. To make the diagnosis of cyclic vomiting, you have to do negative tests for other things to make sure you're not missing anything. And so usually that's why it gets so confusing on board exams, because you can't get 7 tests. You know what I mean? Like they're not going to tell you they did 7 tests that were there. But you will see that sometimes in kids, especially preteen to teenage years, and usually they're in families with strong history of migraines. In TEF, let's see, why is the vomiting more in the morning? Shouldn't it be less? There's less metabolism. No. So what happens is when the kids are sleeping, they're going to be laying flat. And then usually when they change position and the pressure is in their head is bigger, and that's going to be, then they will have the vomiting episodes in the morning. And in TEF, the child will regurgitate just after the feeding. So it depends how the damage is. Like if you've got an esophagus that makes it all the way to the stomach and there's an attachment between the esophagus and the trachea, then those kids will usually have coughing, choking, and vomit episodes and can turn blue. If you've got a complete atresia of the esophagus, then what will happen is they will they can't swallow their own secretions. There's no place for it to go. And also those kids will not be able to feed. They immediately vomit it because the esophagus is incomplete. I don't know how much bilirubin is reduced in phototherapy per day. Usually it depends based on the age of the child, the size of the child, and also the other factor for reduction of bilirubin is hydration. So a lot of times if you can get them on phototherapy and do hydration, you can reduce the bilirubin, but there is not, I've never seen a set number for how much it goes down with phototherapy per day. Okay. Now these are just some fun facts. And the reason I put these in here is because the other thing the board exam likes to do is play with you. And I don't mean that in a mean sort of way. You have to know common, you have to know things that'll kill you. And that's especially important on the PEDS exam or the PEDS section. And then you also have to know things that are normal that you shouldn't do anything about. And those are the hardest buttons to push. I still have a hard time picking the answer of supportive care or watch and wait. Those are two difficult choices, but these are some things that they like to put on the exam that actually are very common and benign. So recognize that newborns, baby girls, may have breast bud development and they can have vaginal bleeding because when they were inside mom, they were getting all mom's hormones. The minute the cord's cut, they come out, the hormones withdraw. So they basically get hormone withdrawal. And so they can have vaginal bleeding, that's normal. They have the breast bud development. The other thing to remember is the first sign of puberty for girls is going to be breast development. And also I want you to think anytime they give you a story, if the child has any breast bud development, they can be pregnant. So, and this is very true for clinical practice at the Children's Hospital. Any child who has any breast development who comes in with vomiting, not feeling well, any complaint that might require medication administration, they get an automatic pregnancy test and triage. Anesthesia does the same thing, and they routinely find 5 to 10 pregnancies per quarter that were not expected. So just remember that if they have any breast development, you do have to put pregnancy, no matter how old they put in the stem. So they put a 13-year-old comes in with breast development, no periods, and you're thinking to yourself, I remember those hormone cycles, what comes here, what comes here. The most common thing for a girl who had periods to stop is going to be pregnancy. The other thing is that this is something that's also congenital abnormality that does not show up until you're older. So if you have a 13, 14-year-old girl whose mom started her periods at 13 to 14, she's got breast bud development, she's got hair, she's been doing all of the normal adolescent development things, but she hasn't had a period. One of the things that, yes, Tanner staging would be helpful. One of the things that you should do is take a look down there. If they tell you in a stem that the child has a blue bulge, think of an imperforate hymen. And so what happens is the blood can't get out. And so these kids will have abdominal pain, can have some cramping, can have cycles, but they won't have periods. And so it's really important to take a look down there, and that's called an imperforate hymen. Males, there's a lot of things that you have to think about here also. One of the most common board exam questions that I can remember seeing is if you have a child with congenital adrenal hyperplasia, and you may remember that's a problem with the pathway for hormone production, Usually the girls will have ambiguous genitalia at birth. So if you have ambiguous genitalia, you're never going to miss that newborn. So the girls with congenital adrenal hyperplasia always get picked up in the newborn period. The problem is the males. The males do not have abnormal genitalia. So what happens is they make it to 4 to 6 weeks of age, and they usually show up with very bad vomiting and dehydration. What else did I show you could show up at 4 to 6 weeks of age with non-bilious projectile vomiting? Very good. Pyloric stenosis. Excellent. What were the lab studies I told you about you would find with pyloric stenosis? Hypokalemic, hypochloremic, metabolic alkalosis. If they give you a 4 to 6 week old male with vomiting with hyponatremia and hyperkalemia, maybe with hypoglycemia, think of congenital adrenal hyperplasia. Okay? So for pyloric stenosis, you're going to have hypokalemia. For congenital adrenal hyperplasia, you're going to have hyperkalemia. Males can have gynecomastia. Fathers always worry about this. Why does my son have breast bud development? That's hormones from mom, and it usually goes away very quickly in the newborn period. Remember, boys, when they start into their hormone adolescent period, they can also have breast bud development, and that's a normal finding. Vomiting, the kids with congenital adrenal hyperplasia are not absorbing things correctly, and so they get kind of, I don't want to say seasick, but they do get seasick. Hypoglycemia is going to make them not feel well. A lot of those kids will vomit. So that's going to be the most common finding. Phimosis is common in uncircumcised male. So when you've got a child that is not circumcised, usually what we tell them to do is just clean what is seen. As long as they're peeing and have a stream, that is absolutely fine. We tell them just to clean the tip. Do not pull it back, because if you pull it back, what can happen? It can get stuck, and that's called paraphimosis. You can see this also in adults. The problem is that a lot of times it's more common in kids. And the reason it is because people are trying to take such good care of things. And when they pull it back too far, it can get stuck. And then we've got a urologic emergency. Thank goodness most of these can be reduced. They require reduction immediately. If the parents come in very quickly, which most of the parents do, then you can manually reduce it. If you can't, then urology is going to have to do a slit to open it up so that it doesn't compress the tissue. What is a hypospadias? If your penis does not have a normal ureteral opening in its normal position, and it's usually underneath it, why don't we want to do a circumcision? And usually they'll give you in the stem, they'll give you all these beautiful normal findings, and then they'll say, on exam of the penis, the ureteral open is below the head of the penis. It's going to be right below that instead of the normal position. Yes, and very good. You need the skin to repair it. So if you've got a child with a ureteral opening, a male in the not correct position, urology respectfully requests that you refer them to them, and that way they can use the tissue from the circumcision to rebuild or do any reconstructive processes that they need. Hydroceles are very, very common. What do you usually see with those? They're usually non-painful, meaning the parents will come in and say, oh, his sacs are huge. It's so big. It's so big. And key things for it is non-painful. So you can look at it and the kid just doesn't care. You get a little flashlight, and a lot of times we can just use like your otoscope, and you just put it there and it shines completely through it, and you can see the fluid around it. Usually they can be of one of two types. They can be communicating, and usually the parents will tell you, you know, when he lays down for a while, his sac gets smaller, and then when he gets up and he's sitting and doing his little baby things, it gets huge. That's going to be a communicating one because the fluid can go in between the two areas. Non-communicating ones stay the same size no matter what you do, and those usually require non-communicating If they're not gone, it's usually surgery at 1 year of age. We refer them at 1. Communicating ones get referred because if it's going back and forth, it could be possibly a pediatric hernia. And so that's why if it's getting bigger and smaller, those get immediately referred to urology or surgery for correction. First sign of puberty in males is testicular size increase. And remember that testicular torsion can occur in both the newborn and the adolescent. Erections, newborns can get erections very commonly. Sometimes it's just before they pee. If you start to see the penis heading upwards, then it's time to put the diaper across it or you're going to get sprayed. And so it's a very common thing to see. So that's my part that I had for the abdominal GI. And I thought I'd run through some pediatric fractures and just do a couple case studies if that was okay with you guys, because it's kind of fun. And I will tell you some of these questions. I'll highlight the parts where you're going to need to know them for the board exam. So a 4-year-old male was playing on the monkey bars when he fell and landed on his wrist. He uses his arm but says it hurts. Vital signs are normal. He has no other injuries. He's checked from head to toe. Arm looks pretty straight, but he's really tender right over his growth plate on the right side, a little bit above the growth plate, just along that edge. So what kind of films do you order? Order an x-ray. Very, very good. Remember when you order an x-ray, and this is a terrible example, but when you order an x-ray in a kid, you should always get the joint below and above the injury, and that will give you a complete film. So if I'm worried about the wrist, we're going to get the hand all the way up to the elbow, and that way you're not going to miss injuries that are there. Good book for peds for boards. Let me think about that. Can I send them a list of ones that you can look at? Because I've seen first aid be used quite commonly, and that one I've had some experience with. There's a couple of the other ones that I'd like to look at though before I said for sure which one I think is best. Yes, and our x-ray is also to check for the growth plate. So when you look at this x-ray, you know, you're going to start and look up along here, and this is the head of the radius, and that's normal. What isn't normal, and I thought I'd give you a little arrow to help you out, this is called a torus fracture or a buccal fracture, and you can see that the cortex has buckled. So see how there's that little peak right by the arrow, and then it goes down. And I did this film. Let me see if my arrows come in like they're supposed to. There it is. This one's a lot easier to see. So see how smooth it is, and then see how there's that little bump there? That's called a buccal or a torus fracture. And these are incomplete pediatric fractures. So these are probably the most benign ones that you can get. In fact, we think we miss a lot of them. But the thing you want to remember is it's an incomplete one. So the bone has not lost continuity with itself. So the bone is still intact. So the big question for these, and this was something that was on my board exam the last time, was do we need to cast these anymore? A lot of people say no. So if it's a buccal or a torus or an incomplete fracture where you've still got everything straight on the bone, some people have recommended these removable splints because you keep better range of motion. Although any of you who've ever casted a kid under the age of, oh, I don't know, any kid age, usually will find that the kids use the casts as weapons and are back to full use very, very quickly. Usually we try and restrict the kids for activities, usually within 4 weeks, they're back to normal. I do not know that that sign has a name. It's the buccal. That's the site of the torus fracture. That's called a torus or buccal fracture. 2-year-old is running at one of our little places. It's called Chuck E. Cheese, where they can go and run around and jump on things and little balls and fall. And she falls and says her leg hurts. She won't walk and lifts the leg into the air. Remember on your board exam, if they will not put weight on their arm, or if they will not use their arm, or they will not put weight on their leg, you must assume it's broken. Kids don't get sprains and strains like adults. So if they are not using something, then you should assume it's a fracture. And yes, you would do another x-ray. And this one is a bowing fracture. So can you see how the fibula is curved? And that's another incomplete fracture. And you've also got a buccal fracture of the tibia, which is that second arrow pointing at where that little point comes out. And usually we're just going to cast these kids, immobilize them, and then follow them up. 8-year-old goes playing soccer, goes to kick the ball, trips and lands on his wrist. What things do you need to check on physical exam? Yes, you are correct. In an adult, it would have broken. It's because if you think about, if you take like a young tree, kids' bones are not as hard and dense as adults on the outside, and the difference is not as much there. So have you ever taken like a branch of a tree and you know how you can bend it? And then remember how when you break a branch, it will crack on one end, and that's called a green stick fracture. It's because you break the cortex. For kids, if they don't break the cortex, that's going to be a torus or buccal where you see that little ridge because it's been compressed. If they break through the cortex, and I've got an example of a green stick fracture I'll show you. But it's like a tree branch. It tends to be more malleable, and that's just the way the bones are constructed in kids. And it does great because it remodels much better than adults. What do you need to check on physical exam? Always, 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 if they give you any kid with anything broken, you're checking for a pulse and nerve function. Very good. Blood flow through the radial and ulnar arteries, and you want to also check that they've got full range of motion and normal sensation. So you do a neurovascular check. And what kind of fracture is this? This is a green stick fracture. And you can see how the cortex is broken on the one bone. I've got the lines going along the bone, and then you can see the crack right in the middle, and you can see the angulation. You will not need to do this for your board exam, but this is something good for clinical practice. And this is going to be how we describe fractures. And so I'm not going to spend a lot of time on this. I just thought this could be good for your reference. And this is again showing you that green stick fracture. Now this is always on your board exam. And usually they give you a picture of something and you have to tell what Salter-Harris classification it is. This is my favorite. Pattern that I like for remembering the Salter-Harris fractures. So there's the growth plate. You can see it. You can see the bone. You can see the growth plate. S stands for straight across. That is a Salter type 1. A is for above. It goes into the metaphysis and takes out part of the metaphysis. L is for lower. Salter 3 goes down through the epiphysis. Salter 4 sucks. It goes through everything. And Salter 5 is R, and it's a crush. So that's, I think, a really easy way to remember what they are. Okay, so which terms did you want me to explain? Do you want me to go back and go through the open and closed fractures? Because I'm happy to do so if you want me to. Okay. Before we do the Salter, we'll go back through the Salter. So open versus closed. You will see that some people still used open fractures. The other word that they will use, they can call them complicated, or there's another old term that they used to use. We use now open versus closed. And that means that if the skin is broken, you've got an open fracture. Closed fractures, you have no continuity between the outside world and the inside world. When you are looking at that, that's the first thing you have to decide. We completely manage open fractures different than closed fractures. Open fractures have a much higher risk of infection. And so the bacteria from the outside can go through that hole and get into where the bone is and cause a much more serious situation. So we like it being closed. Location of the fracture. So anatomically, that's where the anatomy is very important. You want to describe the fracture so that someone on the phone knows what it means. And so usually what we'll do is mid-shaft is going to be mid-shaft. You know, you'll go for your proximal, your distal. And it's important that you tell them it's the distal third. You know, so for example, we'll look at that one fracture and I'll give you an example. Interarticular, if it goes into the joint, it's much more serious. And so that's another important identification. Orientation, transverse goes straight across. oblique goes at an angle, spiral corkscrews. And we see that with twisting injuries where someone would grab, or your foot plants and your leg twists and you get it going around the bone. Comminuted is more than 2 parts with splintering or shattering. Segmental has a single free floating segment. So when you look at this fracture, the way I would describe it is I have a distal radius fracture that is a green stick, and I've got angulation. It's a closed distal third fracture with, it looks like somewhere around 35 degrees, 25 degrees angulation. What they try to do with any of the fractures is to get it within a straight enough range and then cast it. So this one would require reduction. We usually like less than 15 degrees angulation for that area, but you don't need to know that. And then we went through our Salter, and now you've got to name the Salter fracture, okay? So you got a 10-year-old, he's playing baseball. A baseball comes flying at him, jams his thumb, happens to everybody. What would you order? You order your film, okay? So I want you to take a look. There's the distal phalanx. There's the mid phalanx. Let me see if you can see my arrow. See how it comes down? So where's my growth plate? My growth plate is right here, epiphysis. This is going to be the metaphysis. See this hanging there, that fragment? So it came through the epiphysis, up through the metaphysis, and that is a Salter 2, right? There you go. A soccer player twists his ankles while running on his ankle, not both, while running on the playground. He refuses to put weight on his ankle. His ankle is swollen and tender. What should you check? Well, we're always going to do a careful check to make sure he doesn't have any other injuries. We'll check his knee. We'll check his ankle. We'll check the zone in before, the zone in between those two, and then we're going to order some x-rays. Okay. So kids always break. They never take out their tendons. So that's the middle-aged warrior that takes out his Achilles tendon. Poor. I'm over middle-aged, so I guess I should be at risk for that. Our kids tend to break. So look at that arrow. This one went through the epiphysis, up through the growth plate. See the similarity? So this is a Salter 3. This is a very cute little toddler who decided that he was smarter than his mother. And so he was in his little crib with his little railings there. And he thought to himself, I'm not ready to go to bed for a sleep night. I'm just not going to go to sleep right now. I'm going to find a way to get out of my crib. So I'm going to crawl myself up, stick my leg in between those little slits, and throw myself over the top because, you know, I'm a toddler. And as he throws himself over, he twists his leg in between the two slats, and he comes in and he's not bearing weight. And what this is called, and it's very aptly named, is a toddler's fracture. And see the line that's going through the bone? It's a spiral fracture that they get from twisting when they get their foot stuck someplace, like between the slats of a crib, and the leg twists, and that's the kind of fracture. It's called a toddler's fracture. This is another important one that I want you to think about because this is very important. So a 6-month-old presents with not using their arm. What are you worried about? And you will have at least 3 to 5 questions on this topic on your exam. Yes. So we see that this child has a fracture of their humerus. So should a 6-month-old have a fracture of their humerus? No, unfortunately, very good point. The only kids that can get a pathologic fracture are going to be our kids that have osteogenesis imperfecta. Usually these kids have blue sclera, and on your exam, they will have blue sclera. They will have abnormal looking bones on x-ray, and they will usually break very easily. A lot of the kids will have fractures at very young ages, and they will get multiple fractures. Unfortunately, this child is a normal child, normal development. So any, and I want you to remember this because it will be on your exam. Any child under a year of age, if they can't cruise, they can't bruise, and they can't break. So if you are not able to walk, the only reason you break something is if someone breaks it for you. So any child with a 6-month-old with a humerus fracture like that is an automatic concern for child abuse. This is an automatic filing. And if there's a child that is got a femur fracture or a tib-fib fracture, there's no way they can get it normally. That's not possible unless somebody's done it. So it's very important in these kids that you think about abuse. So these are the classic findings for abuse. So if they give you any rib fractures, so if they say a 4-month-old presents in cardiac arrest, has bruises to their abdomen and bruises to their back, where do kids normally bruise? Think about, I'm a 1-year-old, I'm walking, I've got a big head and a little body. So when I fall, where am I going to land? Forehead. So forehead bruises, if you've ever looked at kids under 1 year of age, forehead bruises are so common. So I'm going to fall and hit my forehead. I'm very smart. So I'm going to throw my arms out to stop myself, and I'm going to bruise from the elbow down, and I'm going to drop to my knees and bruise from my knees down. So common places for bruising are below the knees, below the elbows, and your forehead. Kids do not bruise on their abdomens because their arms always stop it and protect it. They don't bruise on their back because they usually don't fall backwards because of their heads. They usually fall forwards. So those are going to be suspicious bruising pattern. Multiple bruises in different stages of healing. Fractures we worry about are going to be, if you get a chest x-ray on a kid in full arrest and you've got rib fractures, I am sorry, that's bad. That indicates to us that someone compressed the child and probably shook them. And the reason they're in arrest is head injury, although they might have other internal injuries. So rib fractures are always going to be abnormal. Scapular fractures, sternal fractures, those are never normal. That's high impact. So those are high specificity for abuse. You've got multiple fractures. A lot of times we'll do a skeletal survey. So if you have a baby that presents, say they're 7 months old and they have a humerus fracture, we will do a skeletal survey because I will x-ray all of the bones of the child. If I've got a humerus fracture and a femur fracture and a tib-fib fracture, I know I've got a problem. Now, we are careful to make sure we don't miss osteogenesis imperfecta because that's important, but the majority of kids, unfortunately, are abused. And let me look over here. I've got to move my little question box over so I can see what your question was. Munchausen's syndrome is very interesting. That's when you've usually got a medical parent with a child who causes the child to be sick. So usually that's going to be somebody who gives their child Ipecac and then comes in with vomiting. That's going to be someone who gives their child something that makes them sick and then brings them to medical attention. Clavicle fractures, yes, go very, very good. Clavicle fractures can be very, very normal. We can even see those in newborns. So what's the classic story for a newborn that has a clavicle exam? First time mom, 9.5-pound baby, comes through birth canal, has a prolonged delivery phase because the baby's huge. And then afterwards, there's a knot in that area, or you see them afterwards. Yes, you can get shoulder dystocia and they have problems coming out. And what can happen is that clavicle can compress and then they can get a fracture. And that's very, very common. All right, I've got about 15 more minutes. Let me see. I've got a couple of pediatric vignettes that I thought I'd run through. So let's do 2 of these, and then that'll be about an hour and a half because I know it's hard to sit still for long periods of time. So you've got a 17-day-old male, and this will be on your exam. What's a fever in a child under 4 weeks of age? Does anybody want to tell me what is the definition of fever in a kid under 30 days of age? Or actually, it's any age, actually. honestly. 100.4 rectal. So any temperature over 100.4 rectal is a fever. So this child has 100.9. So he's truly got a fever. Baby is eating well and has no vomiting or diarrhea, was full term, weighed 7 pounds, 6 ounces, no pregnancy complications. Mother was GBS negative, group B strep negative, and there was no prolonged ruptured membranes. On physical exam, we do have a fever, and we've got a heart rate of 176, 36 respiratory rate, and 80/56 blood pressure. Child has a normal looking head. Fontanelle is soft and flat. That's good. Lungs are clear. Cardiovascular, we don't hear any murmurs. The abdomen is soft, non-tender. Cap refill is less than 2 seconds, and the extremities are warm and well perfused. So what are risk factors for neonatal sepsis? What are risk factors for that baby getting a sepsis type picture in the first, usually week to 2 weeks of life, but it can be up to 3 to 4. Ruptured membranes, mom had a fever, mom had a chorioamnionitis, child has had multiple problems. Those are going to be the major ones. Minor ones, ruptured membranes, foul smelling liquid from the amniotic fluid, low Apgars, prematurity. Those are going to be the minor risk factors. What is the most accurate way to take a temperature? Rectal. If they do, they will not give you axillary on the board exam, but you need to be aware that in babies under 3 months of age, rectal is the only thing that's considered reliable. Oral, you will never do that in a baby. It's only recommended in cooperative children because you don't want to break it in their mouth. Axillary is going to be the least invasive, but it's not exactly accurate. We've got pacifier temperature takes, and it's usually lower than the rectal. And temperature greater than 100.4 is going to be considered a fever. So we've got a 17-day-old with a fever. What diagnostic studies do we need to do? And I picked the under 17 day, yes, sepsis screen, very good. And what would we consider that to be? They get the whole thing, all right? If you are under 29 days of age and you have a fever, I don't care how good you look, you get everything done. The rate of infection in kids under 30 days of age is like 8 to 10% compared to the normal population, because when they're inside mom's protecting them, but when they come out, they haven't had a chance to form their antibodies. We haven't vaccinated them yet, and they have to make that transition to making their own antibodies. So they are very vulnerable under 29 days of age. So if they have a fever and they're under 29, they get a CBC, a cath urine, a spinal tap, a blood culture, a urine culture, a CSF culture. They also get admitted to the hospital, and I'd say everybody does under 29 days gets antibiotics, okay? Now, the one exception is that people will say you don't need a chest x-ray unless they're breathing fast, they have increased work of breathing, or they need oxygen. And I agree with you. If I listened and I wasn't sure that I didn't hear a pneumonia or I heard crackles, I would also get a chest x-ray. Know these antibiotics, AMP and Gent, or AMP and cefotaxime. We do not use ceftriaxone under 2 weeks of age because it does funny things to the bilirubin and can elevate it. So for a child under 2 weeks of age, it's AMP and Gent or AMP and cefotaxime. If they're under 4 weeks, it can be AMP and Gent. AMP and cefotaxime is still what I use, but over 2 weeks to 4 weeks, you can use AMP and cefotaxime. This is just something, and I know they're going to share the slides with you. This is just a little guideline I found helpful. And if you notice, if you've got a kid with an over a rectal temp of over 100.4 with no source and they're under 29 days of age, they get everything and they get admitted. If any child of any age looks sick, everything gets done and they get admitted. The other age groups, 29 to 90, they have not been putting on the board exams because we've been fighting. And so the kids between 30 days of age and 3 months of age, we just have been going back and forth trying to figure out how much we need to do and how little we need to do. But it's made them almost take them completely off the board exams because there isn't 100% correct answer. All right, I've got a couple more minutes. I'll do one more case. So you have an 8-week-old infant born at 37 weeks. Actually, let me skip this one because this isn't as fun as the let me just do, I've got one case that's really cool. Okay, so this is a 5-day-old that presents with a rash around the eye, and you've got a picture of the rash. Mom had no prenatal care and was a very quick delivery at home. Baby had been feeding well and has had no fever, vomiting, or diarrhea. We've got a heart rate of 156, 28 breaths per minute, blood pressure 98/68, and we've got, see on this picture, see how we've got vesicles surrounding the child's eyes. Lungs are clear, cardiovascular exam's normal. Yes, this looks like, what's your concern? Herpes, correct. And so what do you need to do? What diagnostic tests do you need to do? What's different about herpes in babies under 30 days of age? Yes, you need to do a PCR. Usually what we're going to do is we're going to do oral swabs, rectal swabs, making sure we test everywhere. The lesions we'll also do a PCR on. But what else do you need to do? What can happen with herpes in a baby? Remember, I told you mom was protecting them. Now the baby's out. Baby doesn't have any of its own immunity. What can happen to that herpes virus? It can disseminate. And so the biggest concern we have, yes, you will do a lumbar puncture. So for a baby that has what looks like, if they say the word vesicles anywhere around the eye or the nose, I don't care how good the baby looks. We're going to do CBC. We're going to test the PCR. We're going to do blood cultures. We're going to do a spinal tap, and we're going to include testing for herpes in the CSF. And we're going to get the baby started on what magic medicine? Acyclovir, yes. So culture the lesions, HSV, and we want to get this child on acyclovir as quickly as possible. Unfortunately, the consequences of missing herpes are so devastating. If you've ever seen a child, especially if they get CSF involvement, it is terribly, terribly devastating, and usually impacts the child developmentally, et cetera, and sometimes can be fatal.